Hi everyone, thank you so much for coming, and I'm really happy to be here and talk to you about high quality and low carbon asthma care. So I became involved in asthma care from the environmental standpoint because inhalers are such a high carbon hotspot. But sort of over the years of looking at this, I've actually realised that high quality asthma care and low carbon asthma care are actually exactly the same thing, as they are for nearly all health conditions. So, I should just introduce myself. I'm GP at Burn Grief Surgery. Okay. So Debbie and I, I'm going to talk first and then Debbie's going to talk afterwards. And we were sort of thinking about what are the key messages that we want you to come away with at the end of this, and thought we'd put it right at the front. So this is the slide that we basically want you to learn from, which the first is that we really need to focus on asthma care. And that's because largely the morbidity, so the symptoms that people are living with, and the mortality, so the occasional deaths that people with asthma do have, are preventable. And unlike most of the long-term conditions that we come across in general practice, where perhaps it's sort of the wider social and economic determinants of health that maybe we don't feel we have a lot of control over in general practice, in asthma it's actually just prescribing. It's just good prescribing. And so this is completely within our gift to change. But it's something that we can do really just by focusing on two things. And this is what I'm going to talk to you about today, which is, are they on the right medicine? And is it getting to the right place? So in terms of the right medicine, are they taking their inhaled corticosteroid, their preventer inhaler? Think of SABA as a rescue, not a reliever. So that's one of the mindset changes we want today. I'll talk to you about that. And then think about combination inhalers to try and make sure that people are getting the right medicine in. So that's the first thing. The second is it getting into the right place, which is in their airways, not at the back of their throat? And actually most people are using metered dose inhalers, and we'll talk about whether or not it's getting to where it needs to go. And then if we do those two things, then largely we've solved the problem about the inhaler carbon footprint, which I'll explain as well. So if we look at the state of asthma care in the UK, that graph on the left comes from the WHO European Health Information Gateway. And you can see we are at the top in terms of our asthma mortality compared to many of our European neighbours. And that's not changed. If anything, it's got worse over the last 10 years. And this month is the 10-year anniversary of the National Review of Asthma Deaths, where they said most of the asthma deaths are preventable. And actually, when you look at what's happening, it's underuse of inhaled corticosteroids, over-reliance on that short-acting beta agonist reliever rescue salbutamol blue inhaler, and poor inhaler technique. Those things haven't changed. And this really shocked me when I learned about it. So this comes from Asthma and Lung UK's Breathing Unequal report from July 2023. And what's interesting here is how poor asthma control is across the board. But then, not surprisingly, as with every long-term condition, it's also an issue of health inequalities. So if you're from the poorer households, you're more likely to have uncontrolled asthma and less likely to have well-controlled asthma. But look at how few people have well-controlled asthma, and yet nearly everyone, apart from a small group of people with maybe difficult asthma, or a small group of people with severe asthma, and we should be sending them to hospital and having biologics for them, that's a tiny percentage. But the vast majority of our people patients with asthma should be well controlled with really simple therapy, but actually most people are uncontrolled. So what do we mean by that? Well controlled asthma means no symptoms or very few daytime symptoms, so definitely not more than twice a week, no nighttime symptoms, and no restriction on activity. And it's actually really important to dig down with that. Don't rely on your asthma control test, because often people normalise symptoms. So people almost sort of think, well, I've got asthma, so of course I'm going to wheeze a bit when I walk up the hill, or I'm not going to be able to jog. So they restrict their activities in order not to have symptoms. And actually, they should be able to do whatever they want if they're well controlled. So that's a bit of a shock. Okay, what's this got to do with climate and ecological crisis? Why are we even talking about low carbon? Most of you will be aware that the climate crisis is actually a health crisis, because all of those things in the middle that we're all aware of have impacts that impact our health, because they impact life, they impact well-being, they impact health. And if we think about this just for our asthma patients, the same things that are causing air pollution are the same things that are causing the climate crisis, which is the burning of fossil fuels. And we know that air pollution makes it more likely that you're going to have asthma exacerbations, but it's also a cause of asthma in the first place. So that's one impact. Increasing allergens. Allergen seasons are getting longer, they're getting stronger. That's going to have an impact. Heat. When we have heat waves, we have more asthma exacerbation. So that's just 3 examples of how it might impact on our asthma patients. And the WHO has said that the climate crisis is the biggest health threat in the 21st century. But that's also our greatest opportunity, because nearly everything that we want to do to basically mitigate the climate crisis is exactly the same thing we would be doing even if there was no climate crisis for public health. So it's all the same stuff. So we're talking about cleaner air, better diets, more physical activity, more access to nature. And the good news is for us is that those impacts are immediate on our patients, and they're really significant. Now, back in October 2020, the NHS recognised that, okay, so we're a healthcare provider. We care about the health not just of our populations now, but also in the future. We have to make sure we're responsible, that we're not doing any harm. Globally, healthcare is responsible for 5% of the emissions, and that's double aviation, actually, so it's not insignificant. And they had 2 targets. So we're the first health service in the world to say that we want to be a net zero service. We've got 2 targets. One of those targets is for the emissions that we directly control. And metered dose inhalers, which are the most common inhalers prescribed, contribute to 13% of the entire NHS's carbon footprint. So it is a particular hotspot. And NHS England has got a target of a 50% reduction in that carbon footprint very soon. Okay, let's talk about right medicine. So how do we optimise asthma care through prescribing? Now, I'm just going to, that airways diagram that I'm showing, there's a printout here. If you go to the back, there's loads of printouts, so please do take one from the primary care development nurses. If there's one thing that I've changed in my practice that has absolutely transformed the conversations that I have with patients with asthma, it's using that asthma diagram. And it's amazing how few people who've got asthma have ever been explained what asthma is and how their inhalers work. So now when I talk to them, I'll say, okay, so, this is a normal airway. And you can see there's a big hole there, lots of space there for air to move in and out. In asthma, they have inflammation in the lining of your airway, so a bit like a cold. There's less room for the air to go in and out. When your airway is inflamed, it's sensitive. And that means when it comes into contact with its triggers, whether that be pets, whether that be pollution, whether it be pollen, the muscles around the airways tighten and narrow further. And that's when you're experiencing your cough, your wheeze, your shortness of breath, your chest tightness. When you take your blue inhaler, your reliever inhaler, all that's doing is releasing the muscles around the airway. And it will do it temporarily, it will do it for a few hours, and it gets you back to that inflamed airway. But actually, what you really need to do is treat the inflammation and then get yourself back to a bit of a normal airway, and then you won't have the symptoms and it won't be triggered. So the real treatment to asthma is an inflammatory condition, and the treatment is anti-inflammatory. And we really need to explain that much better. And I've had so many patients have a bit of a light bulb moment sort of using that airways diagram. So Debbie's got airways models that she might demonstrate later. So you can choose 3D options as well. She's made her own. You can buy airway models as well, but you can use that diagram. And that's available online on the Greener Practice website, or there's loads, like I said, there's loads to pick up if you'd like your own copy. And that's really important, because if you look at the data, the problem is we've been prescribing separate inhalers. And if you've got 2 inhalers, one of which relieves your symptoms and one of which you need to take regularly, but you don't know what it's doing or why you're taking it and it doesn't make you feel any better, then probably you're not going to take it. And actually adherence to the Preventer inhaled corticosteroid inhaler is really low in real world studies, ranging between 15 and 54%. So it's really important people actually understand why they're taking it in the first place. And I found the diagram really helpful. the right place we'll talk about later, and people getting it to the right place. The reason I put this slide up is because it's interesting. Not only patients, but I think healthcare practitioners, perhaps we don't have high enough expectations of asthma control. And we want to be preventing these symptoms to try and improve people's quality of life. But we also need to prevent future risks. And even people with mild asthma, people who wouldn't even consider that they had a long-term condition, wouldn't think of it as something that's impinging on them at all, are at risk of asthma attacks if they're not being treated. And they can be fatal. So 10%, I think, Debbie, of the deaths that happened for patients who had mild asthma. And then, of course, if you're needing to take oral prednisolone because you've had an asthma exacerbation, only 4 to 5 oral steroid courses over your lifetime is increasing your risk of osteoporosis, diabetes, cataracts. So we want to be reducing the risks of that. And if you've got inflamed airways that have basically stayed inflamed and no one's ever treated them, then eventually you're going to get chronic lung disease from airways remodeling, or you're at risk of that. And the reason I put up this slide is because it's going to make sense when I put the next slide up, which is basically to say, if our patients with asthma had good control, what we would expect is that they would use lots of the maintenance preventer inhalers and very few of the rescue inhalers. And I think actually one of the things that we would like a mindset shift on is not thinking of the blue inhaler as a relief, but thinking of it as rescue. So if you had a patient with angina and every month they said to you, oh, can I have another GTN spray because I'm getting chest pain? You wouldn't go, oh yeah, here you go, have another GTN spray. Because obviously it's working for you, it's working for your chest pain. You'd be going, oh my goodness, why is this person needing so much GTN spray? We need to get them in and sort out their angina management. And it's no different with asthma, but somehow we seem much less reluctant to allow people to just continually using their rescue medication. And it is rescue. We shouldn't be thinking of relief. Relief sounds like a good thing. Oh, I'm feeling relieved. But rescue, that's a warning sign. And I want people to start thinking about their blue inhaler as a warning sign. If people are using too much blue, this is a warning that maybe their asthma is not controlled. Anyway, so that's what we'd expect. More maintenance and fewer rescue. What we actually find, and the UK is at the bottom on that chart on the left, is that we prescribe pretty much mostly rescue inhalers and very few maintenance inhalers. And if you look at this in a different way, then 83% of our reliever inhalers for patients with asthma are going to people who are overusing it. Why is that important? Well, we know SABA over-reliance or SABA overuse is defined as needing more than 2 SABA inhalers a year. Only 2 SABA inhalers a year. If you're using 3, your risk of asthma attacks goes up, doubles. And the more you use, the higher your risk of asthma attacks and the higher your risk of asthma deaths. The opposite is true for the ICS. So actually the life-saving drug here is your ICS drug. Yes, temporarily, if you're having an asthma attack, yes, temporarily, your blue inhaler is important, but the life-saving drug is your ICS drug. That's the thing that's actually treating your asthma. And I put this up because one of our key messages is no one with asthma should just be on a blue inhaler. BTS sign guidance, note, step 1, regular preventer. There's no sabrolone. I know NICE in the past had step 1 sabrolone. They're doing a joint guidance, that's going to come off. That will not be there anymore. But this is, well agreed amongst everyone that nobody with asthma should just be on a basically dilating drug for the airways, temporarily relieving symptoms. But in the UK, 34% of our patients are on sabrolone. And actually, it's worse than that, because we already know that if you prescribe people separate inhalers, they tend not to use their preventer inhaler. So effectively, 2/3 of our patients are not treated. Okay, going back to the carbon footprint, so integrating this back in. So when you think of the carbon footprint of inhalers, and some of you will already be aware of this, sometimes what people do is they jump to what's the low carbon alternative. But there are 2 ways to think about the carbon footprint from anything. That is, how much are you using, and what type of thing are you using? And actually, if we could take most of our patients who are uncontrolled at the moment with asthma and make sure that they're well controlled, 2/3 of our carbon footprint would be reduced because we would be using fewer rescue inhalers. And then the other third is, are we using the lowest carbon inhaler possible for that patient? And this is just a study that came out a couple of years ago, which demonstrates that. So I know it's a very busy slide, but basically the red is the people with not controlled asthma, the green is controlled asthma. You can see carbon emissions much higher for the people who are not controlled. Okay, I am not going to talk about this because Dab's going to cover this in detail, but the combination inhalers are potentially transformative for asthma, because what you're doing is you're putting that preventer inhaler and the rescue treatment in the same inhaler. And because formoterol has an indistinguishable onset of action from salbutamol, so basically it's the only LABA that works really quickly, you can use it in the same way that you'd use salbutamol. And it's so much more convenient. It totally overcomes the real-world problems of people not using their preventer inhaler, removes the need for a blue inhaler completely, lowers your total dose of steroid, and it's simpler for patients. I've only got one inhaler to remember. But Dab's going to go through that, and this is just reinforcing that the global initiative for asthma recognise that given how people use their inhalers in the real world, that combination inhalers are the preferred treatment for all steps. Okay, right place. So this is just to say we are completely out of step with the rest of Europe in terms of the inhaler devices that we prescribe. For some reason, DPIs have been around for a long time, but we haven't been offering people a choice, probably because we're not familiar with them. But we are out of step. So we tend to prescribe metered-dose inhalers in this country. In Europe, they tend to prescribe far more dry powdered inhalers, and some of the Nordic countries, they prescribe barely any metered-dose inhalers. And we know they're just as clinically effective. And we know that we're not doing well in terms of mortality and morbidity. So we know that at a population level, as long as we do this safely at an individual level, we should be able to do that quite safely and effectively. So how are we going to choose? On what basis do you make a decision? So I've got some inhalers out here, and if you want to have a play with them, I do recommend that you have a play with the different inhaler devices. I would say the most important thing when it comes to trying to fit the inhaler device to the patient is asking them, show me how you use your inhaler. I would guarantee, and I'm sure most of the nurses here will agree with me, that if you ask a patient to show them how they use their inhaler, the vast majority of them, A, are not using a spacer device, because spacer device is really low in the real world. And when they're using their metered dose inhaler, instead of doing coordinating down and doing over 3 to 5 seconds, because it's a really slow breath in, they're doing over 2 to 3 seconds. Now, if you do that with a metered dose inhaler, where basically the idea is that it's propelling the medicine in, so the propellant is pushing it into your lungs, it's going to hit the back of your throat and it's not going to get into the airways. So it's not getting to where it needs to go. Now, sometimes what happens is people get used to that sensation of it hitting the back of the throat, and that becomes their feeling of, oh yeah, it worked. It hit the back of my throat. So you need to explain that in order for them to feel comfortable with changing the device. You shouldn't feel it at all if you're using it well. So what you could have that patient and sort of say, oh, well, you're not using it properly. Use a space device. That's not going to happen. They're not going to use it in the real world. Adolescents are not going to use it in the schools. Yeah? Or you could just say, actually, your inhalation technique fits a dry powdered inhaler. Why don't we see if you're better off with a dry powdered inhaler? Because then it might actually get to where it needs to go. Can I just ask you to show the in-check device, Deb? So now you don't need to use one of these. This is an inhaler training device. You don't need to use one of these to work out what kind of inhaler somebody needs to be on. But you can see, maybe I'll show you on a slide in a bit later, but you can see here it says DPI and MDI. And when you take a breath in with one of these, it will tell you whether the breath in that you've taken is suitable for a dry powdered inhaler or a metered dose inhaler. You don't need it to assess which one is best, but it can give patients and clinicians a lot of confidence, particularly when you start doing it. If you're not very confident, you've got that objective measure that tells you whether or not it's a good idea. They're not very expensive, and there's a little bit of a discount code on the Greener Practice stand if you're interested in using one of these. And also Deb's bought loads of mouthpieces if you want to give it a go and just see which range you would be on. Okay, so inhalation technique. The second is, has the inhaler got a dose counter? My favourite dose counter is in the Nexthaler because it's really nice and big, but you do get, actually I'm not going to try and open that. You do get dose counters on all the DPI inhalers. And it's interesting to me now, thinking about it, I didn't used to think about this before at all, but how did we expect people to know when their inhalers are running out, particularly their inhaler that they're only supposed to use when they have symptoms? Because actually, if you shake it, that doesn't tell you. And most people, they've done studies on this, most people are either throwing away inhalers that are half empty, and some people are using inhalers that are completely empty, but they think they're not empty because when they shake it, it still looks like it's got propellant in it, and that's not really a good guide. There's no good way of knowing whether your Ventolin or your Salamol inhaler is empty or not. So dose counters can be a really effective way of tracking whether or not somebody, when the inhaler is empty, and that can be really helpful for the patient. It can also be helpful for adherence. The other thing is, dry powdered inhalers don't need spacer devices. So if a person's not using a spacer device, you might want to think about, are they better off on a dry powdered inhaler? Now, there are some people who need a metered dose inhaler. There are few, but there are some people who need it. And there'll be people who just prefer the metered dose inhaler. But that's going to be a small minority. So those are the people who are very young, very old, severe disease, who you're worried that when they have an exacerbation, maybe don't have the inspiratory flow to take that quick and deep breath in, and they should stay on a metered dose inhaler. So I think the message that I'm trying to say there is that we ought to be fitting the inhaler device to the patient, not expecting the patient to use an inhaler that they're struggling to use or that they won't use correctly. But there will be people who can use all sorts of inhalers devices equally, and it's only at that point that it becomes not a clinical choice, an environmental choice. So we should be thinking about the inhaler mostly from a clinical perspective. What is the best inhaler device to get the drug to the right place for this particular patient? But the reason I put up this slide is just actually, if you ask people what kind of inhaler they prefer to use and you give them a free choice, and there's not even an environmental question there, it's just a free choice. Which inhaler would you like to use? Which type of device do you prefer? Most people choose a dry powder type inhaler, and that's even when they were already on a metered dose inhaler. And if you ask people, because most people do care about the environment, would you consider changing for environmental reasons? 60% people will say yes, 21% people would consider it. So we should be offering people that choice anyway. Next slide. Okay, so one of the things that I've learned from sort of doing this work over the last few years is it's all about familiarity. So you're not going to prescribe something that you haven't handled and that you're not familiar with. So my top tip is get placebo devices, completely free. Drug companies will give you whatever you need. Those 4 types that I've put up there are the ones that are on the Sheffield formulary. They're all really relatively easy to use, but have a go. Get confident with them. Be aware of how to use them. They're all really actually quite easy to use. Just not going to spend too long, but for instance, the Nexthaler, can't do too many things at once. Just click it, breathe out, breathe in. You've got your easy haler. With this one, you do shake it, you press it, you breathe in, and then with your turbo haler, I'm not doing this very well, am I? you take the lid off, you click it one way, you click it back, and then hold your breath. I didn't do the holding breath. You meant to hold your breath for up to 10 seconds after each one. But it's really quite straightforward to use them. And I think having placebo devices and showing people the choices just means that people can have a look and see what they like. But it's important to get yourself familiar with them. I've already talked about the in-check device. That works for all different types of inhalers. And then there's also the tray inhaler. So if somebody does need a metered dose inhaler or prefers to take a metered dose inhaler, it's really good for work, training them to use it correctly, because it whistles if they are using it correctly. So that's a very good device to have handy. And this was just to remind you all that there's lots of videos that Asthma and Lung UK and Right Breathe have produced. So when you have already said to your patient, this is how you use your inhaler, send them an Accurix link with a link to the video. There are already pre-made ones that you can cut and paste from a website that I'm going to show you in a minute. But yeah, and then also, actually, the first time you change it, you can put 4 NMS on the prescription, which is New Medicine Service, and then the pharmacy should also reiterate how you use the inhaler. Next slide. Okay, next slide. Okay, so this is really, really briefly just to say that for those patients who want or need an MDI, there are differences in the carbon footprint, and the one that you're probably familiar with is for salbutamol. So you've got your Ventolin Evohaler and your Salamol. Both contain the same drug, both just as clinically effective. The reason for the big difference in the carbon footprint is that Salamol has less of the gas than Ventolin. And perhaps what I didn't explain very well is that the reason that metered dose inhalers have such a high carbon footprint is that the gases in the propellant are hydrofluorocarbon gases, and they're sort of 1,000 to 3,000 times more powerful than carbon dioxide equivalent, which is why that's such a high carbon hotspot. That's why that happens. And you can see that all the oranges are the dry powder inhaler. So there are differences between the different inhaler devices, and you can sometimes make a change there. But this is very much after you've done the clinical thing about which is the best inhaler for the patient and making sure that they're on the right medicine. Next slide, please. And then another really simple thing that we can think of. So if somebody's got asthma and they're stable, we have a tendency to do 2 puffs twice a day, but there's no clinical advantage in that whatsoever. And actually often people forget to take their second puff, or they don't wait long enough, or they don't shake their device before they take their second puff. So if somebody's on 100 micrograms of Clenil, 2 puffs twice a day, and they're stable, and they need an MDI, and they're better off on an MDI, then why not give them a 200 microgram Clenil, 1 puff twice a day, and their suddenly 200 dose Clenil inhaler is lasting 100 days instead of 50 days, half the cost for them, half the carbon footprint. You know, it's pretty win-win. Next slide. And this is just a reminder to say that with metered dose inhalers, we really need to make sure that they're clinically incinerated, because that degrades the F gases and it makes them much less harmful to the environment. So we probably ought to be reminding people to take it to the pharmacy. And again, loads of these if you want to take them on the desk behind. Next slide. So one of the things that we recently produced is, thinking about how do we optimize that asthma review? What's happening? Why is it that people are not really being educated about what asthma is, learning how to manage their own condition, getting the right inhaler for them? And we've produced this visual guide, and it's been endorsed by Primary Care Respiratory Society, Asthma and Lung UK, the Association for Respiratory Nurses, to support that asthma review. And it's very much question-based. How is your asthma affecting you? What do you do when your asthma gets worse? How often are you using your inhalers? And making sure we check objectively how many of those Sabra inhalers have they had? How many ICS inhalers have they had? And then really making sure that we use, it's got links to the airways diagram. Has anyone explained to you what asthma is and how your inhalers work? What would help you remember to take your preventer inhaler every day? Many people benefit from using a combination inhaler. Have that conversation with them. And then let's talk through how to manage your asthma, because obviously there are other things they can do. Maybe breathing exercises would help, maybe avoiding air pollution, all of those kind of things. And then obviously we want to make sure that they've got an appropriate PAP, and I think they're all available in the asthma and lung table behind as well. Next slide, please. So that's the second section of the, I'll just maybe explain. It's on 2 slides because it was a funny shape, but basically it is 1 page, and you can get a copy from this from the Greener Practice thing, but you can also get it from the website if you want, and on the website you can click onto links as well. So again, it's just basically saying, don't just tell people how to use their inhaler. Ask them how they're using their inhaler. That's the important question. It's the demonstration. And if you're not doing your asthma reviews face to face, you don't know if somebody's asthma is well controlled. The ACT is just one way of assessing somebody's asthma control. It gives you something, but it is not an asthma review. And if people aren't being seen face to face, they're not getting that understanding of how they're using their inhaler, which is the way that the medicine gets in, then we're not really doing a review at all. So that's one of the things that maybe we could go back and have a little look at. But it's the demonstration, how are you using your inhaler? And then you go to deciding, okay, what should we do? And it's a sort of a flow chart to help you with that. Next slide, please. Okay, so I just thought I'd put it all together in a case that I had a few years ago. So this was a 30-year-old lady who came in to see me. She actually didn't come in for her breathing at all. She came in for a skin complaint, but she happened to mention when she was there that she had a cough and she'd had it all through the night. She was having to use her blue inhaler most of the time. The thing that she was bothered about was that it was keeping her husband awake. And she said, well, you know, I'm absolutely fine in the summer. This is only a problem in the winter. And it was interesting that, you know, she had her reviews in the summer. I'll come back to that in a minute. When I asked her, you know, do you find it difficult to remember to take your preventer inhaler? Yeah, I do sometimes forget. And when I do remember, I take it usually once a day. And she wasn't using a spacer device. Click. So when we looked through her notes, she was on a really low dose of ICS inhaler, probably because she'd been reviewed in the summer and she was fine in the summer, and so nothing ever got stepped up. And nobody had actually looked at how many inhalers she'd actually been prescribed over the last 12 months. Because if you looked at that, you'd see she'd had loads of rescue medication and very little treatment. Next slide, please. So I said, okay, show me how you use your inhaler. And she did exactly what nearly everybody does. She was using a quick and fast breath with her metered dose inhaler. So we had that conversation. I didn't realise I put these on separate lines. I'm sorry, just click through. So we had that discussion about how asthma is inflammatory. You know, you showed the airways diagram with her. I told her, you know, really, you should be able to do whatever you want. You shouldn't be getting any symptoms. You shouldn't be waking up at night. We discussed increasing her ICS dose and putting her on a combination inhaler for simplicity. We also said, well, maybe you're better off on a dry powder inhaler because you're using a quick and deep breath and you're not using a spacer. And then I followed her up in 6 weeks to see how she was getting on. It completely transformed. She had no coughing at night, started going to the gym. As far as she was concerned, the most important thing was she'd lost weight. And her PEFR had increased by 20%. No need for extra reliever breaths. Sometimes people are quite anxious when you put them on a combination inhaler. They still think they need the blue inhaler. You shouldn't need to prescribe them a rescue pack because sometimes it can confuse things. But sometimes I will prescribe a rescue pack and then review it. She hadn't needed to use it. And sometimes I'll go, well, okay, let's do that for a year. And if you don't need to use it, then we'll stop prescribing that for you. Next slide. Okay, so just really briefly, what are the quality improvement tools that are available for you? And when we started this, we started sort of writing a guide. A few of us got together across country and we thought, okay, what are the principles and shall we write a guide? And then that was helpful. And then we thought, actually, nobody's got any time to do this from scratch. We need to make it as step-by-step and as simple as possible. So we've created this asthma toolkit, which has lots and lots of projects in it for quality improvement. Next slide. And when we started off, this is a really important point that I want to make. When we started off, we sort of mapped when do our patients actually come into contact with us? Because the sort of reactive thing that I get is that, oh, our nurses deal with asthma. Just talk to the nurses. We don't need to do anything. Or our pharmacists deal with asthma. But if you think about how your patients access care, they'll come and see GPs or first contact clinicians when they've got symptoms. And that might be the first time you suspect asthma, or it might be because they've got an exacerbation. What are you doing with those patients? Are you giving them a blue inhaler? Are you giving them a blue inhaler and then they've disappeared? They thought, oh, that's my treatment, my blue inhaler, and then they never come back for the follow-up with the nurse? And then how do you follow them up? You know, that was happening for us in our practice, and we had to look at that, and we had to look at the coding. When people need repeat medication, is anyone sort of bothered about how many blue inhalers they've had before? Medication reviews, annual asthma reviews, emergency hospital attendance. I mean, that was another thing that came out of the NRAD, is that people ought to be seen in GP surgeries within 48 hours of having an asthma exacerbation, and that's still not happening. So is that because they're being coded as A&E attendants instead of coded as asthma exacerbation? Is there a way of training people to do that? So there's a lot of things that are system changes, and some of them are really simple system changes. So you might just want to change your prescribing interval for SABA. So instead of it being default 28 days, it's 84 days or 180 days. So people just can't keep getting them. You know, it triggers an alert. Next slide. And so what we did is we've sort of developed these really step-by-step quality improvement projects, completely free to access, in these 4 different areas. So diagnosis, disease, device, choice, and disposal. And they have all the resources that you want. We've even created patient-facing leaflets, patient-facing videos, if you want to change your asthma control, the invite that you send people, if you want to change your prescribing interval, if you want to send people a video about what asthma is, we've got all of those resources on there. So just have a little look at that. And I think that's me done. And then, Deb, shall we go to the next slide? I think that's me done. Oh yeah, key messages again. So we always start and end with the key messages. So just, again, we can change this. We need to focus on this. We need to just do a few simple things. Right medicine, right place. And if we do that, it's also greener. Thank you.